congratulations organisers for having me to speak today. In the interests of everyone's lunch, I'll try and move through as quickly as possible. No conflict of interests to declare. So as a background, Vigil have done a recent recalculation and about 209,000 people are living with Hep B. And most are from culturally and linguistically diverse backgrounds, and Aboriginal and Torres Strait Islanders contribute a significant proportion. There are certain local government areas that, due to their makeup, their populations, have a greater burden of hepatitis B. And the census method can be used to calculate numbers within those local government areas or census areas. The National Hepatitis B Strategy paper has recognised that scale-up is important to avert unwanted mortality and morbidity, and conservative estimates about 15% of people should be living on treatment. And the Hepatitis B strategy has also got uptake as a key indicator. Just a brief word about what is a Medicare local. So a Medicare local, as part of national health reform, Medicare locals have been created across Australia. They're areas of primary healthcare responsibility, and they vary from very large Medicare locals to urban, more densely populated Medicare locals. The job of the Medicare local is to set priorities within their primary healthcare area and specifically look at needs of their population. So just on the right, we have a graph that's been used a few times during this conference, looking at notification data for chronic hepatitis B in Melbourne. And, didn't press the pointer. This is the area around Dandenong, Springvale, and around Maribyrnong in the west. And on the other side, we've got the Medicare locals. So it just shows southeastern Melbourne we looked at, inner east Melbourne, Macedon Ranges and northwest Melbourne, and southwestern Melbourne. So for the scope of this project, we chose to look at 10 Medicare locals, and we used 2006 census data. So this used the extended country of birth tables, and a birth country prevalence was allocated for the 284 categories in that census table. And we calculated both upper and lower cases for 64 local government areas. The Northern Territory, it's a discrete Medicare local, and we treated that as a whole, and that's because there was just a lot of local government areas that would have taken a lot longer. From Medicare, we got de-identified prescribing data by LGA of patient, not on HIV treatment. And the time period we looked at was June to November 2011. Uptake was calculated just as a simple proportion, and untreated cases were calculated on a 15% assumption. So to the results. So in those 10 Medicare locals we looked at, there was a total population of 4 million, and estimated cases of hepatitis B of 56,000, and this is a third of cases from the 2006 census. So obviously with the new census that has to be recalculated. There was a range in prevalence by in local government areas, so from 0.6 to 3.5%, and by Medicare local of 0.5 to 1.56%, which is approximately twice the national prevalence. Treatment uptake by local government area varied more widely, from 0 to 14%, than by Medicare local. Of interest, it was most people who were on treatment were in New South Wales and Victoria. So 86% of those treated nationally were in the two states, and there was about 2/3 of the cases of hepatitis B nationally were in those two states. This table just looks at the numbers. So the Medicare locals were here, and they were big population Medicare locals, so around 800,000 in Western Sydney, down to a fairly small Medicare local in terms of population, but not in terms of size, in far west New South Wales. These are the lower case estimates generated by Medicare local, the upper case estimates, and a lower and upper prevalence. The calculations using the figures used for prevalence for the lower case estimates reached approximately similar case estimates to other models that have previously been done, just over 171,000 on those 2006 census estimates. So moving to actually the uptake of antiviral treatment. So on the far right is the uptake, again in 2006, for using the 2006 census data for antiviral treatments. So we've all looked at and hopefully signed the Auckland Statement, which says treatment is below 3%, and that's that recalculation with the new census data figures. In the urban Medicare locals, especially in Sydney and in eastern Melbourne, treatment uptake was actually higher than the national average. With southwest Sydney having the highest uptake and the east of Melbourne higher than the west of Melbourne. Also just looking at the total number of cases, so each of these Medicare locals is quite different sizes, and so the actual number of cases per Medicare local is quite different. This slide just illustrates that even though southwest Sydney has good rates of uptake, they still have substantial numbers of untreated cases. If we look at that further, so again looking at southwest Sydney, and I'm not a Sydney local, but it goes from more densely populated local government areas out to places like Wingecarribee and Wollondilly, which are much more sparsely populated areas, more rural. And even within this Medicare local, and there has been, this Medicare local has been previously a focus of the Be Positive project. So if we look especially at these inner areas, there's quite a lot of variation in the uptake within a local government area. So even for adjacent local government areas that should be roughly fairly close to services, very similar distances, there's quite a difference in terms of the uptake. So Australia-wide, the uptake was 3.47% on those 2006 census data, which is approximately 23% of chronic Hep B patients who are receiving treatment who require treatment. And the uptake in those high priority locals in Melbourne and Sydney was greater than the national uptake, but they actually still contain about a fifth of the untreated cases across Australia. Presumably the difference in uptake is multifactorial, related to access to services, community awareness, medical practice differences. And rural areas and remote areas had very low uptake. Limitations. From our colleagues in Darwin, we know that actually some of this data we receive from Medicare is incomplete because the numbers on treatment at the Darwin Liver Clinic are greater than the numbers provided by the PBS data. There's an inquiry to Medicare in process, but those inquiries can take a little while. And we presume it's possibly due to a different funding stream for drugs, maybe to do with the territory. All these calculations, as I mentioned throughout the talk, were 2006 census data. So they're conservative, and Medicare locals we need to recalculate those figures because we've had a large amount of migration in the last 5 years. Whenever we use the census method to estimate numbers, communities in Australia may not reflect source country prevalence, and where possible local data was used for prevalence estimates, but that's always a possibility within the data. And it doesn't include co-infected with HIV. I mean, this actually wouldn't really change the uptake figures at all. It informs where treatment services are lacking, but it doesn't actually tell us who is being adequately diagnosed, monitored and screened. So the implications, it informs this, our national strategy indicator by Medicare local, and we can estimate uptake over time to monitor the impact of innovative programs like general practice prescribing, community Hep B nursing support, aimed at increasing treatment uptake for people living with hepatitis B. These case estimates and numbers of people on treatment have already been provided to Medicare locals by ASHM in partnership with Federal, and in Victoria co-signed by GPV, General Practice Victoria, and also the Cancer Council of Victoria. And that's assisted in actually just raising awareness, so numbers talk, people like to see numbers, and helping raise awareness of hepatitis B as a priority health need within certain areas. So in summary, hepatitis B isn't evenly distributed, and it affects culturally and linguistically diverse communities and Aboriginal and Torres Strait Islander people. The treatment uptake for chronic hepatitis B varies between Medicare locals, and case finding and monitoring and treatment all need to improve in these Medicare locals, but also in other areas with high priority populations if we're going to prevent excess mortality and morbidity. Thank you.